Good morning. This is the 1591st day of continuous webinar conducted by International Forum for Promoting Homeopathy. Today, our guest is Dr. Jessica Monteiro. Let us begin the session with 1 minute silent prayer. Thank you all. The International Forum for Promoting Homeopathy comprises of homeopathic lovers, students, and doctors, and we have 3 sessions every day. The first session of our day is already over in Hindi from 7:30 to 8:30, and from 8:30 to 9:30 we have the international session in English, and from 9:30 to 10:30 local language session in Malayalam. All these sessions are going in a good way, and we are uploading the videos of the same on the very next day itself, so that you can, those who miss the session can watch it again at the YouTube by searching IFPH Homeopathy. You can subscribe the same without paying any penny. And this is the purpose of International Forum for Promoting Homeopathy is to take homeopathy to every household around the world. And this is what the purpose of this forum. And we are very happy to say that we are able to achieve the 6,000 subscriptions by now. And definitely you need to subscribe and share it with your friends, and not only the homeopathic doctors, but also the homeopathic lovers around the world. And let me introduce the guest of the day. That is Dr. Jessica Monteiro. She has completed MD and has MSc in psychiatry also. She is working as an associate professor in the Department of Medicine, KLE Homeopathic Medical College, Bangalore. And after completing her MSc in psychiatry, she has intense course in research methodology and biostatistics from KLE Academy of Higher Education and Research at Bangalore, and she is pursuing her PhD also. Has completed a certificate course in food and nutrition, has been a part of the curriculum redesigning of BHMS course conducted by Rajiv Gandhi University of Health Science, Bangalore in 2014, and presently the member of Committee of Collaboration and Community as of the research cell of KLE Academy of Higher Education and Research in Bangalore, and has been external and internal exam, the university exam of different homeopathic medical college in India, and presently the principal investigator of intro research, effect of calendula efficiency in wound healing, a cell culture study, and integrated founder study of the efficacy of integrated approach of both homeopathy and Ayurveda of hair fall. And she has presented various papers at international as well as national level, and presented more than 10 research papers as oral, as postal presentation, as various national and international conferences, has been a resource person for a guest lecture on the topic of mind and body health and menstrual hygiene at various schools in Bangalore. Last time, a doctor took a class on effective communication of patient care. In this evening, Dr. Jessica will be sharing the second part of the same. So we proudly welcome Dr. Jessica to this session. Yes, doctor, please raise your hand. I cannot find you. Yes, I shall make you co-host. Yes, doctor, you are co-host now. You can open the video.
Yeah. Thank you so much, Dr. Danish. It is really heartwarming to come back to this session and be with all of you. And thank you once again for inviting me back. I'm so glad to be with all senior homeopaths around the globe. I always wait for the sessions at this forum. Just a second, I will just share my app.
Yes. Yes, we can see it. You can make it. Please. Yes. Full screen.
Okay. Thank you once again, and I welcome all the participants to this session. I hope we will have a good interactive session. This is in continuation to the session I had a month back with the topic effective communication in patient care. In the last session, we spoke about the basics of communication, where we learned about what is communication. More precisely, we did not learn, we discussed what is communication. We discussed what is the need for communication, what are the types of communication, and what are the skills we would require when we are communicating with patients. The statistical data in communication or in healthcare says 80% of the problems the patient and the doctor face while communicating or while interacting with each other is due to communication. And it's not only the research which is progressively upcoming in the communication area in medical education, but so many years back, Dr. Hanneman so precisely put it forward in our aphorisms about why we need to be able to communicate well. He says that in aphorism 6, the unprejudiced observer is supposed to, he goes on to say in the whole aphorism, all the perceptible signs, the homeopath who grasps with requisite carefulness the whole group of symptoms. So one of the important area probably I have understood in this aphorisms is that we need to be able to communicate and understand what our patient is saying. And communication for most of us is just understanding what the patient is talking, but communication is always a two-way process. So when we go to the definition of communication, it is a process of sharing information. It's not just talking, it's sharing of information, feelings, and emotions, which efficiently results in understanding what the patient or what the doctor is trying to convey to the patient and vice versa. So continuing with what we did in the last class, I will just directly go into what are the skills of communication we have completed. So we'll just go into what is active listening and what is the principles of communication. So when you want to communicate to the patients or with anybody else, communication in general is not only to our patients. Nowadays, the scenario is we also need to communicate to other people who are associated in patient care. So people associated in patient care would be right from the time the patient is entering your clinic. Everybody around the patient or involved in patient care is somebody who is involved in communication. It could be right from the person who is there at the maybe the watchman or the at the parking area. It could be your receptionist, it could be your pharmacist, it could be the other discipline doctors to whom you refer. So these are all the people who are a part of what I call is the circle of care of the patient. So when the patient is coming to you, of course, you are the primary endpoint or you are the primary area of communication. But at the circular end, we have so many other people who communicate, and how you communicate to all these people is something with which strengthens the patient-doctor interaction and communication. So when we are talking about the principles of communication, there are 7 C's of communication. One is the communication has to be complete. Whenever you are communicating, the message should contain all the facts needed for the desired reaction. One of the important error while communicating we know is we assume that we have communicated. We assume that the communication has occurred. And most of the time, it is incomplete communication, and most of the misunderstanding, miscare in communication or miscare in treatment takes place because of errors of communication. So it is very important that we complete the communication and it was contained all that was needed for a desired change or reaction. There has to be clarity in terms of your vocabulary sometimes, or it need not be that you have to speak something like, in a very affluent way, but your words in whichever language you are speaking must be very clear. And for your words to be clear, it's very, very important that your thoughts are very clear. If your thoughts are clear, your words automatically get clear. You need to be very concise what you are saying, because the patient requires to understand the central message of what you are talking. We may talk everything and sometimes the central message is missed. So to be very concise is very important. Being courteous is very important. One must communicate in a friendly manner. Communication, especially in healthcare, should be correct. You cannot communicate something which is incorrect, because that again falsifies your communication. It should be very accurate. All the words, language, information should be very, very accurate. It should be concrete. So it should be very specific, not vague. And you should be very considerate about the emotions and sentiments of the receiver. Here we are talking precisely of communication in healthcare. So when we are talking about patients, our emotional and our sentiments of the patient should be something which we should consider at a very priority level when we are communicating. So moving on to the communication. When I'm talking about communication, we all know what is communication. We really need not go for a class for communication, especially our students. But we feel that communication is inborn in all of us, but it is something, it's an art. Communication is an art, and art can be learned. There are certain technical things in communication which I will be dealing here. Elements of communication. What are the important elements of the communication? So there are so many communication. So in this, there are four components. One is the sender, the receiver, the message and the channel, and the periphery, or the noise or the environment, which is important. So you should be very, very clear that your sender and the receiver is properly involved in the communication. The channel in which you are communicating is very important. The medium, for example, when we take our patient doctor interaction or our case taking, once we are done in the same process of case taking, and when we are consulting a patient, we have so many types of communication involved. We have verbal communication, we have non communication, we have written communication when you write the prescription. So you cannot just verbalize your prescription. There, a written communication is very important. So you should know what is important, what type of communication, which the types of communication we have dealt it in the last session. So here, these are the four important components of communication, and you should be very, very precise about what is the channels of communication, and also what could be the other things which may break down your communication. It may be the environment, it could be the noise that may not allow your communication to take place promptly. So the noise, the environment, everything plays a very important role. And this is called as the Stott-Hall's communication theory, where when you are communicating, you need to keep in mind some very important components. That is the physical context. What is the type of patient, whether you are physically talking to the patient, or whether you are telephonically talking to the patient, or you are just writing it to the patient. So that is very important. What is the physical context to the patient, or you are the first person talking, or you are at the third position talking. So this is very important. The educational background of the patient is important. We cannot talk to everybody at the same level. Sometimes the patient, so we are talking about two important components, that is encoding and decoding. So when you do not take all these components into consideration, your encoding and decoding process may go for a toss, because the education level of different patients, a literate patient may be at a different level of decoding your communication, whereas a literate patient may be at a different level. Again, the gender is important. The ethical environment in which you are is very important. What is the role of the patient in the society is again something very important, and the cultural context. So these are the different components given by Stott Hall's communication theory. So in general, what I would like to convey through this is, whenever you are talking to the patient, being aware about what you are talking to, whom you are talking, where you are talking, what is the background, what is the cultural context, is something which helps our communication to be very, very effective. So let us go a little more into the two important components of communication, that is encoding and decoding. What is encoding? Encoding is a process of turning the thoughts into communication and encoding the message properly. It could be, when you are encoding, it could be a face-to-face communication, a text communication. It should be at what level of what conscious effort you are making to encode it properly, taking into account all the noise and all the environmental distractions. So this is encoding. So when you encode it properly, then the decoding becomes more easier. When you encode and send the message to the channel, the audience then decodes or interprets the message for themselves. Decoding is a process of turning communication into thoughts. For example, you may realize that you are hungry and you encode the following message to your friend: I am hungry. Do you want to eat something? As your friend receives the message, they understand, they decode it, and then they respond back to you whether yes, I want to eat, or maybe I do not want to eat. So how you are encoding? So I am hungry is something which is really not a complete this. I am hungry. Do you want to eat now? So this is something, an example where you are, this is just an half done message. So when you want the person to respond to you completely, and you do not want miscommunications to occur, a completeness is very important, and that is why you should be aware that you need to encode and decode your messages properly. So this is the process of how the communication occurs. There is a sender, message, receiver, and one very important component where we miss to understand is your feedback. Your patient or your respondent or your person who is opposite to you, who is your receiver, always gives you feedback. It could be a verbal feedback, or it could be a non-verbal feedback, or some non-verbal cues. It is very, very important for us to be aware about the feedback what you are receiving. That gives us the understanding whether my message is being promptly encoded or and promptly decoded. So especially when we are sitting in the consultation room and we are taking our case, be very aware about what the feedback the patient is giving every moment. It could be through the non-verbal communication. Most of the feedback in the patient doctor interaction would take place when the patient is, like, giving us a non-verbal cue about what they are understanding. I would like to go a little ahead about the different models of communication. What are the different models of communication? This helps us to be aware about how we are communicating. Probably it makes our communication more technical, and it gives us that kind of introspection and awareness when we are talking. So we have this Aristotle mode of communication. Now, what is this Aristotle mode of communication? It is a type of communication which is just one way communication. It is just the person who is the speaker is just speaking, and the audience are just respond. They are not responding, they are just receiving the message. They are the passive audience. They do not have an option to speak there. So in this they would have an option to speak, but it is an one way communication. So this type of communication you see in large gatherings, you see in lectures, in seminar halls, where the audience is a large, we have a large audience and the speaker is speaking. This is most of the time seen in big rallies where the communication is to convince the patient. Aristotle mode of communication is basically the very old type of communication where initially the physician used to only speak and the patient used to only listen. There was no much interaction between the patient and the physician initially, or in the very olden days. So this type of communication can be used in today's era or today's interaction between the patient doctor. Yes, there are some kind of areas where we can use this type of Aristotle mode of communication, where we just want to communicate very simple things, and when we want to convince the patient about something very shortly. So this mode of communication is hardly used in 5% of the times or during our communication. So this is one mode of communication or model of communication where there is only one way communication. Now, there is a traditional model. Traditional model is something which we just discussed, where there is a sender, receiver, the feedback, encoding, decoding is very important. And in our day-to-day activities, most of the time, we use the traditional model of communication. But we go wrong in communication because we miss the important components. We do not pay attention to the feedback which is received. We only know that we have to talk. We talk and we do not wait for the receiver to decode it. We are not aware, or we do not want to be aware to receive the immediate feedback through whatever ways available. So that is the traditional model where most of us communicate into our day-to-day activities, or most of us when we are taking our case or consultation, we usually tend to go by this traditional model of communication, and it is the natural way of communicating. But we need to go a little beyond the traditional model when we are communicating. And this is what I think Dr. Hahnemann always uh, focused on, the biopsychosocial model of health or health communication. This type of model is usually used in health communication. That is the biopsychosocial model of communication. In this psychosocial model of communication, we try to understand all the three aspects of the receiver. We try to understand the communication. In this type of communication, we want to be a little more aware. There is awareness plus introspection happening in this biopsychosocial model of health. And the awareness is in three different aspects. One is the important aspect, the biological aspect. So when I am communicating, very important at our level of case taking or consultation, in general, this is something which we need to be using in our health communication. So in biological aspect, when a patient or we are communicating to our opponent or the receiver, we need to understand or be aware at the biological level at which the patient is. For example, the patient comes and says like, I would just like to explain this model with a small example. We have an XYZ patient coming and saying, Doctor, I am not keeping well. I feel very anxious. My mood is not good and I feel very fatigued. I feel very weak. Probably these are the presenting complaints. So now when I am communicating, I will just look at what could be the biological cause of what the patient is saying. So the biological level of communicating. So this could again be at the level not only with the patient. If you just want to go away from the health communication and apply this to any other communication, for example, if the child is communicating something, you have to understand that at the level of the biological level of the child. So this is how we try to understand the biopsychosocial communication at the biological level. Next is at the psychological level. Coming back to the patient example, when you say that when the patient is saying that I am feeling weak and I'm feeling anxious, so from the biological level, it could be some problem with brain, or it could be some kind of ADHD complaints. It could be some organic level complaints which we need to be aware of. Second is the psychological. Why is the patient feeling? Is there a psychological aspect to what the patient is talking? So next is you go at a higher level. From the biological level, you go at the psychological level. So now your communication becomes more empathetic. You are going into a psychological level where you are trying to understand the patient, why it is happening. Is there something wrong at the psychological level? Is there something, is this a symptom of anxiety which the patient is going through? Is the patient talking to me because he is anxious? Is the patient talking to me because he is sad, or he is having some he is not having a good day? So now when we just go away from the health communication, we can apply this to maybe our colleagues when we are talking. If somebody is talking to us and communicating, if you are communicating and responding, you can ask the question to yourself, introspect, why is the patient talking to me? And why is the opponent talking to me or this receiver talking? What is he trying to? This at the psychological level. And the social is, you can see the circumstances why the patient could be communicating in that way. It could be some problem at the peer level, circumstantial level. It could be some family relationship problem, trauma. So the biopsychosocial model of health is so similar to what Dr. Hahnemann used to say, that you have to understand, it's a holistic approach of understanding the receiver or the sender. So in our case, this is a holistic approach of listening to and understanding our patient or communicating with our patient. So this model is what we need to be frequently using, of course, because we are trained in organon, we are trained in how to take a case, trios of case, we are trained, we need to put it into action even at the level of communication, because this is a very important model of communication which is indicated in or which should be used in health communication. Next is the transaction model of communication. In this transaction model of communication, here the difference is both the sender and the receiver are communicating or responding at the similar time. So they both are active similarly at and together. Whereas in Aristotle or traditional model, one is active and the other is passive. In transaction model, the minute the receiver, the sender is saying something, the receiver is already communicating, the receiver is already responding. For example, this transaction model, you can see it during our case taking as well. The minute the patient enters, you are asking the patient, how are you? And from there only, before you finish your question, the patient is already entering with answering. So you do not have any space for a pause. There is no question and there is no answer. It is similarly occurring. So in the transaction model of communication, there is active participation of the sender and the receiver simultaneously. Now, this transaction model of communication, all of us would have experienced when we are taking case. Most of the time, you are asking and the patient is immediately responding. It could be response in terms of your verbal cues. It could be in response to your, it could be both verbally, non-verbally. Here the response is most of the time in non-verbal communication. And sometimes you would see if you are this transaction model of communication is very important. This happens at the initial phase of communication, when the patient just enters your, when the patient just enters your just a minute, I'm so sorry. When the patient immediately enters your consulting room and you are doing something on your laptop, or you are repertorizing some case, and you, while doing this, when you ask the patient says, good evening doctor, and you are looking at your laptop, and you are just by your hand you are waving to the patient and you're saying, come and sit in. So what you are doing is, you are, the patient is talking, before the patient ends and you are ready, you are sometimes communicating. So transaction model has to be very cautiously used, and when we most of the time use this transaction model in communication, from the receiver's point of view, we need to be very cautious about how we are communicating in this model of communication. So when you look at the case taking process, we see at some point of the time we are using the traditional model to be very commonly used. The biopsychosocial is, as homeopaths we usually use. Aristotle model and transaction model is not much used, but when you are using, probably it could give way for miscommunication. When you are using Aristotle model of communication, you should be telling the patient why you are doing that. For example, the patient says, the doctor only talks, he never listens to me. So I will, in the next slide, I will just show you what are the results of my a small survey which I had conducted, which showed how Aristotle model of communication, which we unknowingly use, and it is misinterpreted by most of our patients. So this is all about the types of or the models of communication which we need to be aware while we are communicating. There is a 738 and 55 rule of communication. This is called as the Meherbian communication model. It says that 55% of communication occurs by our body language, and 7% is only by the actual spoken words, and 38% is how the words are said. So when we are communicating, we try to only use our words, and we say that when we are using the right words, we are communicating well. No, this model is a scientific and proven model, and it says 55% of our communication only takes place by the non-verbal or the way we communicate through our body language, and 38% is how we said, the way we welcome our patient into the consultation room, the way we address to them, how are you feeling, what brings you here, rather than saying like, okay, tell me what is happening. So the words what you are trying to convey is you're just trying to ask the patient. So this is very important for us, because most of us have learned how to communicate through our experiences. But today, communication is something which is a double-edged sword for all the health professionals, where when we communicate, we are able to do so much good for the patient, and in return we are there is a lot of patient satisfaction and doctor satisfaction. But when our communication is misunderstood, we so many times it lands up into legal problems, it lands up into violence against doctors. I would like to just emphasize one example which recently took place. This is, I think I have just uh, re-emphasized this in the last but I would again like to re-emphasize this. This is an article which was recently, I think 2 or 3 months before. This was in Times of India, in which there was a violence against a junior resident in one of the hospitals in Chennai, and this is the cutout of the newspaper, in which the whole thing tells us about the interaction, what happened between the resident and the patient and the relative. So there was a violence on the junior resident. I will just I have just underlined certain things, what happened in this communication. Here, Dr. Balaji, who was severely wounded in the attack, is currently undergoing the treatment. The incident sparked a political uproar. The accused allegedly attacked Dr. Balaji out of frustration over what he perceived as improper treatment for his mother, who was previously undergoing under the doctor's care. Dr. Balaji didn't even look at me during the consultation. So the problem what the patient says is not about the treatment. The patient had this problem saying the Dr. Balaji did not even look at me during the consultation. So the problem, how much our patients look for our verbal cues. She allegedly adding, my son has too much love for me. He is also whatever. Then Vignesh's mother further claimed that he had been misinformed about the own diagnosis, insisting that she was told that she had a stage 2 cancer rather than stage 5 cancer. Now, again, there is a miscommunication which has taken place here. There is miscommunication in the words which has been used by the doctor. And again, if I just do not want to read the whole thing, the incident took place on Wednesday, showing Vignesh casually walking out of the hospital after the attack, before he was being caught. So again, the patient had this problem that the doctor simply walked away. So when the doctor is talking to the patient, without even completing the conversation, the doctor simply walked away. So these are the 4 or 5 problems which most of us face, or the patients misinterpret what we are doing. So that's very important, that how a wrong body language or wrong non-verbal cue can lead into so many so many problems during the patient-doctor interaction. So that is how it is very important that we have importance, or we give a lot of importance to the body language. Poor communication causes a lot of misunderstanding and hinders work. The ability to communicate effectively and sensitively is the central dogma of all medical activities. So not only communicating effectively, nowadays we need to be very sensitive about how we are communicating. The evidence that good communication improves history taking skills leads to accurate diagnosis. So when the patient is talking, when we have active listening, most of the time the patient is telling the diagnosis. Dr. Peter Osler already said, listen to the patient, he is already telling you the diagnosis. So when you be actively listening to the patient, we already have the diagnosis in hand. What are the common errors in communication? Very importantly is the improper tone. Maybe you are using the right words. When your tone is not proper, you tend to again miscommunicate. This is one of the important error of communication. Non-listening or non-active listening. We tend to be listening, but when we are not actively involved in listening, that is a very important error of communication. The choice of words we make is very important when we are communicating. Again, communicating completely inadequate information is one of the important error of communication. Again, attitude, the attitudinal way in which we are communicating, that again is wholesome in the improper tone, the attitude, all these are important part of our non-verbal communication. So these are the common errors which can occur in communication. Effective patient-doctor communication is the central clinical function in building a therapeutic patient-doctor relationship. That is why communication is the heart. If clinical functioning is the heart of communication or heart of a medical communication or clinical function, effective communication is that art. It is important to deliver high quality of communication in healthcare. Most of the dysfunction or dissatisfaction which occurs during the patient-doctor interaction is due to our communication errors. And one of the problem which we face is most of us feel that we are able to communicate well. It is our overestimation of our ability that we can communicate well. So I will just show you. I conducted one research, both qualitative and a quantitative research, in which we sent this question: what according to you is an important barrier in a patient-doctor interaction? And we had so many other options. One said lack of communication, in which most of the respondents said that 45% of them said that it is the lack of communication skill is one of the important barrier. Second is lack of sensitivity to patients' cultural background. So this is the output of our survey for communication skills among health professionals, particularly among homeopaths. And a third one said that it is not able to communicate in patient's own language. And when I went to the second question, in which areas of communication do you feel improvement is needed? Non-verbal communication was the lowest. 4.17% was non-verbal communication. So this was the respondents from all the PGs, UGs, and the consultants. Around 250 people participated in this survey. Where most of them felt active listening is one of the area where we need improvement. Building trust and rapport is something which is very important, but non-verbal communication is okay with all of us, and that is not much area which needs improvement. When I had a qualitative research where the participants of the qualitative research were patients, relatives, homeopaths, and people from the what I told you about the circle of care. It was the physicians, surgeons. So all the people involved in patient care, I had a qualitative research where I did an in-depth interview for all of them. There were 40 participants. Although this is not yet published, I am just putting out this slide, where in this qualitative analysis, the most important barrier which came out is body language. So when you go into introspection, when the patients go into introspection, when we sit back and see why the communication is decreasing between us and this, body language was something which took the highest place. So again, the ambiguity is there. We feel that we are communicating well, we do not pay much of attention to our body language, but when you go into the analysis from the patient point of view, even when there was introspection among the homeopaths, body language was something which came out as the outstanding barrier, or which needs improvement. Next was listening, being aware, and complete information. And most importantly is talking in the local language. So apart from this, there were so many other things, but some of the important things which this research showed us, we need to be very aware when we are talking. Being aware and introspecting is something which will make our communication very, very active and efficient. Because this is the part two of our communication, I think we have come to the last slide. I'll just go with quickly with the barriers to communication. So what are the barriers which normally we face during communication? One is the physical barrier. So when we are communicating, sometimes maybe the consultation room where you are talking could be one of the area why there is improper communication. Maybe sometimes it is the sitting arrangement also. Sometimes it is your physical, the doctor is not really, he is tired, physically he is tired. Probably these are the areas while communicating. There is a framework by WHO, World Health Organization, which sat back, I told you in this, we discussed about this in the last session. There was a consultation which took place in 2011, where the South Asian countries sat together and had a framework, like, why there is this patient-doctor relationship which is deteriorating, and communication skills was something which was identified to be one of the top important barrier. There, when you go through that framework, it is a framework book. When you go through that framework, a very good example is given there by WHO. He says, when the doctor is sitting in the clinic, he is seeing 100 patients. When the 100 patient enters, for the doctor, it is, I am being tired the whole day and I am seeing the 100 patient. I just want to finish up the case and I want to get up. And that is why he communicates, and maybe the communication is not great. He is hurrying up. But for the patient, he is waiting all through the day, and for him, it is the first interaction with the doctor. So for him, it is, the doctor feels that, the patient feels that I am waiting outside for so long. The doctor even does not have time to talk to me. He is just hurrying up with my case. He is not even listening to what I am trying to tell. So WHO, the World Health Organization, gives this example as two sides of the coin, where they say this is the doctor factor. The doctor factor is, there is lack of time from the doctor. There is the doctor feels like, he has to rush up with the case, and so many other things. But from the patient point of view, it could be the language barrier. The patient feels like, he is not being given enough attention. So taking into consideration this communication barrier is something which even the WHO is working through. And it next is barriers caused by the wrong choice of medium. Sometimes when you have to use a written communication, you are using a verbal communication. It could be the semantics, which is like, sometimes it could be due to the different meanings which are used. It could be due to cultural barriers. Sometimes one culture may not communicate the same thing what the other culture is communicating. I told you in my research, one of the important thing which came up is, when we are communicating, being aware about the cultural background of our patient plays a very important role in communication. Again, the psychological attitudinal barriers during communication is something which is very important, and this may cause a very important barrier. So again, when we go through the case taking by Dr. Hanneman, he says the patient or the doctor should be completely in prepared. If you go through the aphorisms, where the mental space of the doctor or the homeopath should be very clear. That is what Dr. Hahnemann says. He should be mentally prepared. So our mood, our attitude should be really great when we are communicating. Barriers caused by various perception. It may be the level of understanding, the comprehension problem. Sometimes we do not understand the language, so we are not able to comprehend properly. So these are the different barriers of communication, which we again need to be aware. So what I feel is, when we are communicating, one shortcut to be effective or efficient in communication is being aware. I always use this word, aware and introspect. When we are aware of what we are communicating and simultaneously we are introspecting of what is communicating and what feedback the patient is giving us, most of the time our communication gets right and effective. So the take home message would be, communication is the art of exchanging information between people and the means of connecting them. Good communication is the key to success. Effective communication is the physician's most powerful tool to improve patient care. And I have experienced this in my this, and as homeopaths, all of us have experienced this, that when we communicate well, our patients, our totality of the symptom just booms up. And if knowledge of medicine, surgical skill, and clinical acumen is the craft of medical practice, then communication skills are the fine art of practice, I feel. So, in the last session, I think we did not have enough time for a discussion. We were out of time, so I kept my session only for 45 minutes to complete and hopefully to have some interaction. And with this, I am so thankful to all of you to be actively and patiently listening to this session. Thank you so much.
Thank you, Dr. Jessica Monteiro. It's a very, very important session, and you have done justice to the subject, and you have shown the beauty of communication in this presentation. Yes, there are certain obstacles also there. All these things were mentioned, and and you even projected some of your research work in this session. Everything is good and okay. It's the time for discussion. Those who want to discuss the session, please raise your hand. I invite Dr. Beatrice to begin the session from Germany. Yes.
Yes. Thank you very much, Dr. Jessica. It was very, very interesting topic and very important for us as medical doctors. And what was very, very interesting for me, you were pointing out that our body language is so important.
Very,
And
important.
I knew, of course, but we don't observe ourselves. We don't have a mirror, but we see in the eyes of our patients if they are more smiling or a bit like this, looking at us. So perhaps all medical doctors, all students, medical students should be taught that first of all, give a smile to the patient. That's very important. And also, thank you very much to emphasize the organon when Dr. Hahnemann was talking about the first interview. And it is really impressive in these times. Nobody was taking so much interest in the patients as he did. Nobody was writing everything in the books. Nobody would say it's not enough just to listen to the patient. We also have to ask the relatives, the wife and the family, whether it's really clear. So he was so much interested in the patient and with so much empathy. It is really outstanding. And without that, I don't think homeopathy would have survived. But that is a basic. Sometimes we are not so aware, but the basic is, and you are totally right, the interaction between a clear observer or prepared observer with interest and the patient who is suffering. So at least we say, one of my teachers said to me, of the homeopathic teachers, he said, if your patient is laughing or crying, You did something right. So thank you very much for that very, very beautiful presentation. And just to give a little joke, but it was clear for me. When I did start as a student with 19, 20 years at the university, and it was allopathy I was studying here in Germany, I saw the professors, the medical doctors talking to us, but the body language normally was so bad. I said to myself, how is a person who is moving in that way can cure a person? I was asking with 20 years myself. I did not like it. So not all of them, of course, but all my homeopathic teachers, I can say, they had a very nice way to behave and to move, and that makes a big difference. So thank you very much for that great presentation, and please go on to give that information to our colleagues.
Yeah, I am working on a module which can be probably put it at the national level, where the module is for students, where we can teach them the different aspects of communication and also interprofessional communication, because I'm doing my fellowship in medical education. So my topic is actually communication, health communication. So I'm preparing a module where it will be helpful for all our budding homeopaths to learn the components and the art of communication even before they are put it into the world of practice. So hopefully that works out. And one more very important thing which came to my mind is when I was having this qualitative research or qualitative in-depth interview, one word which the patient and their relatives told me, which strike me, is when the doctor is not able to behave or communicate properly with the receptionist or the watchman or the other grade 4 workers in your hospital with a good body language, how is such kind of consultant or doctor going to treat me? So they gave me a elaborate, like, about their experience, where the doctor was really very good in talking to them, was verbally communicating very well to them, but the non-verbal communication towards the receptionist was negative, was not matching with the verbal communication. And then they told me we were not comfortable, not because the doctor was not talking to us well, but the non-verbal communication, if they do not know how to communicate with the other people who are involved in the patient care, probably that doesn't satisfy us. So we should not only be aware about how we communicate with the patient, it is important how we communicate to the relatives. It is important how we communicate to other disciplined doctors in case of referrals, when we communicate to technicians during investigation, when we communicate to the pharmacist, when we communicate to the receptionist, because in one patient, all of these people are somebody who come in contact in interprofessional communication. So this is something, a big learning for me during my research activity, which I would like to again emphasize. Yeah.
Okay, thank you, Dr. Beatrice and Dr. Uh, Jessica, for such a beautiful question answer session. And now it's up to Dr. Manoj.
Thank you, Dr. Thanesh and Dr. Jessica. I must thank Dr. Beatrice just now, because she is highly qualified. It's a post-graduation as well as 2 specialties are there. She's a pediatrician as well as dermatologist. So that the body language is totally different. What Dr. Jessica told theoretically is applied by Dr. Beatrice. I just watching that. The body language, the expressions, the attitude, the tone is totally practical on. With a laugh, with always a smiling face. So you can see, you just look at the Dr. Beatrice. She's always expressing, she's always in the happy mood. So that's the most important thing, wonderful thing. Then again, I have suggestion that a few of our teachers at least need some medicines. Like sepia, they are totally indifferent. They don't know how to laugh, how to respond. Then also the tone, the sound modulation is totally failure in monotonous way, especially in the organ classes. Very, very boring because they cannot talk. How to communicate. Then another thing is you mentioned about this non-listening. In the recent years, because everybody is always in mobile phone, they don't know how to communicate, especially new gen people. Then another interaction is that the use of this software, they're always typing what the patient is telling to record, not on the paper. There's another obstacle. So then they will not get enough time to look at the face of the patient. So these are the major attitude problems. Then again, this type of topics or time should be given at the second year of the graduation course. So when the students are before entering to the practical clinical classes, they should be learned not only students but also teachers. Anyway, you did start a nice presentation. You should continue it and keep it up. And the National Council of Homeopathy should pay enough importance to your topic. I hope so. Thank you.
Hopefully. Thank you so much for your active listening, and thank you for having me here once again. Thank you. Good
Yes,
night.
yeah, as we used to say that our teachers need to change the methodology of teaching as well as communication with the students, because the students are here as homeopathy students. They need patience to get patience. That is what I must say, because then only if the person is waiting, and just when you get a patient, you just simply sit there and watch what they have to say. But instead, what nowadays thing is happening here is that most people are coming with some records, and you just look at the record and then go right away into the prescription and simply not asking about the things behind the illness, and one find it very difficult to find the right remedy. But instead of just some are going that right away going into pathological prescription, just like it's a fever, so we can do that remedy, or it's a case of diarrhea, so we can do this one remedy, without asking about further details. Some people used to come, doctor, I have a lot of problem in my I have consulted so many doctors. Then they will come up with the scan report, blood report, through examination report, all this report. Then the doctor directly go into the report and then going in the prescription way. That's a very, very bad methodology of prescription as far as a homeopathic doctor is concerned. You just wait and see what happens with the what the patient has to tell to you, as well as what the patient is showing in front of you. This is what I would like to add to this session. If anybody want to ask, yes, Dr. Ambaresh, sir, you
Dr.
want to?
Dr. Indrani raised the hand. Dr.
Oh,
Indrani.
Indrani. Dr. Indrani, please raise.
Indranil. Okay.
Ah.
Thanks, sir, for allowing me. Doctor, it was a very informative lecture. One thing I would like to ask, that many a times I have seen during case taking, after some few minutes, sometimes the patient loses the concentration and he is busy in other thoughts, or he looks here and there. We ask some questions and they don't pay attention. So how should we softly communicate with them to come back to normal? Can you guide us for this?
Yeah. So in that, very importantly is the patient is giving us feedback. So when I am talking about this is he is just not able to communicate, like, we can use this biopsychosocial model here, because if he is losing his concentration, he is not able to this. For us, like, going into one higher step, why is he doing that? And making where, like, just asking ourselves this question, is he worried about something, or is there some anxiety because of which he is hiding, or is it some problem which is not allowing him to concentrate? So I think using the biopsychosocial model, when the patients do not when the patient come out with such presentation, is something which will enhance us to communicate well. So here we know that the patient is not responding, but going into that extra step, why he is not responding, and just trying to understand the patient's viewpoint would probably answer our question and help us to go ahead with our process of case taking, I guess.
Okay. Thank you, madam. Thanks for the explanation. Yeah.
Okay, thank you very much. And it's the time to wind up the session. I invite Dr. Beatrice to say what thanks to the session.
Yes. So, Dr. Jessica, thank you so much for your very clear and very easy understanding presentation. And Thank you very much, all the colleagues from IFPH, for your daily care to go on with that project. So let us be aware to communicate well and to give every day, to give some smiles to our friends, to our family, and to our patients. So thank you so much.
Thank you, Dr. Beatrice and Dr. Jessica Monteiro, and those who attend the session in this evening. Tomorrow, we will have a session from Dr. Nikhil Trivedi, and Dr. will be talking about hiccup and homeopathy. With that, we come to the end of the day, 1591. Thank you all. Good night.
Thank you. Thank you all.